going like that. Yeah, very good afternoon to everyone present here. Here we are going to organize the e-paper presentation associated program for the GERICON e-conference, the first time ever conference for the geriatric physiotherapy in India. And now I would request our e-paper presentation team from Sri Anjaneya College of Paramedical Sciences, Dr. Jazil sir, can you please handle the rest of the things for this program?
Sure, ma'am. Yes, ma'am. Good afternoon, everyone. Welcome to paper presentation ceremony. So I would like to welcome our judges jury of our today's session. The first one, Dr. Arun Balasubramanian, Grade 2 Physiotherapist, Government Headquarters, Hospital, E Road. Welcome you, sir, for the session. Secondly, we have Dr. Dharman Vyas, Physiotherapy PhD Scholar, Assistant Professor, Parul University, Gujarat, India. Welcome you, sir, for the session. Thirdly, we have Dr. Vishnu Vardhan, Professor, Ravinayar Physiotherapy College, Wardha, Maharashtra. Welcome you, sir, for the session. Fourthly, we have Dr. Srihari Sharma, Assistant Professor, Dayananda Sagar University, Bangalore. I welcome you, sir, for the session. And I would also like to welcome all the participants for today's paper presentation ceremony. And I would like to just bring in your attention some of the rules and guidelines. We have a total of 7 minutes of presentation, in which 5 minutes will be allotted to you and 2 minutes for a question and answer session. The presentation time will strictly, you will receive a buzzer to start the session, as well as 4th minute will give you one warning buzzer. Okay, and the 5th minute will end the session by another buzzer. So just kindly check in your internet connection as well as audio and video, just to be prepared. Okay, so good luck to everyone. And now we would like to move on to the first presenter for today's under UG category. Presentation number 2021-0000-003. The title of the presenter is Geriatric Population Framework and Planning, COVID-19, a Literature Review. Judges, please note the first candidate for our presentation, number 2021-0000-003. Can we start, sir?
Yes, please. Yes, please.
So I'll give you a buzzer just to before. Harshika Gupta, are you ready?
Yes, sir. Thank you so much, sir.
Okay. All the best. Okay, I will give you a buzzer. Okay, once I give you the buzzer, you can start with the session.
Sure, sir. A very good afternoon, respected all teachers and dignitaries and all present over here. Today I'm here for the GERICON e-paper presentation with the theme Physiotherapy Care for Older Adults. And my title is Geriatric Population Framework and Planning, COVID-19, a Literature Review. Here my content on which the perspective on which the coming slides is based on, that was like a background introduction, objective review of literature, methodology, conclusion, results and references. So what was the background and the introduction? Before I start or proceed with my topic, I would love to introduce that why I choose this topic. As I get the opportunity to first time in this my graduation period, that I get learn about the specific protocols about the geriatric and the present condition, the pandemic situation, COVID-19. So I think this was the first and foremost opportunity for me to learn about as I can specific in a geriatric related to the COVID-19. So this is the basic concept and this is the basic aim to achieve this and to create the awareness. And of course, if I am presenting the paper with the help of literature review, I can also create the awareness among the people, among the students, among the seniors, juniors, and the all over the India or across the country, to create the awareness for providing the evidence-based practices. So, what was the background and introduction? Geriatric care in nationwide well-being emergency is a serious concern as exalted the fatalities among geriatric population. Henceforth, the glow in COVID-19 pandemic indicates implies scarcity elasticity. A robust approach is extravagant requisite that require an unified exigency alacrity by addressing geriatric population care. The objective, as I already share, the aim of the study cognize the role of physiotherapy, spread the awareness and the effectiveness for evidence-based practices by this contest. The methodology, where I collect my literature reviews, articles, and what was the data selection criteria. So for the first, the online portals I use for this research for my literature review, that was a PubMed as a most format priority, Current Literacy, Google Scholar, Scopus, Academia, Sodhganga, ResearchGate, and Academia. Another, the three significant scientific studies was found related to my title, that was a geriatric population framework and planning COVID-19, our literature review. The study selection criteria. There was exclusion criteria. I just mentioned here 5. The 4 most important on the priority basis. That was the first exclusion criteria is the language of publication is not any other. The second, the publication is not an article in a peer-reviewed journal and Bowell assessment. Third was a published article not payable. And the fourth one, other geriatric cases, including the excluding the other than the COVID-19. And the fifth one, the other approaches except the physiotherapy and the physical inner. Same with the inclusion criteria that included, that was the language of the paper should be the English. It should be published in the authentic portals, that was using the Journal of Physiotherapies. Another was like the only including that was a geriatric population COVID-19, and other cases are excluded. So now this is my review of literature. Review of literature that I included the 3 literatures that I, which is my parent articles, which is meshed to these articles. That was first article was the Patrick and Word Search was, which is published in the June 2020, which is published in the Indian Journal of Health Science and Research, with study title as a goal of care and COVID-19, a good framework for dealing with uncertainty. And the study concluded that using good framework may help ease of prognosis of patient recovery rate. And the second was Brocardi and Ragat Giaro Mukherjee, was a year published in the April 2020 and published in the Journal of Indian Journal of Nursing and Care, with the study titled as COVID-19, a geriatric emergency. The study concluded geriatric physiotherapy aimed to avoid the collapse of the intensive care unit. Another third study was Human, done by the Homeo Mazumdar and Hossein Anupadas, which was published in the March 2020, and the published in the Journal of Geriatric Social and Work, which is titled as Geriatric Care During Health Emergency, Lesson Learned from the Novel Coronavirus Disease, COVID-19, developing such proactive plans for emergency preparedness response, the burden of mortality and morbidity.
We'll move on to the
result that literature offers an inclusion. So, this slide, please.
Yeah, continue.
The literature offers an incidence up-to-date, a concise framework for clinician to plan conduct, and evaluate goal of care, the good framework. The conclusion is next slide, please. Physiotherapy has a key role in enabling older people to maximize their body's potential to enhance mobility and independence. The aim of geriatric physiotherapy is to improve a patient's quality of life and prolong independence and physical well-being. Indeed, the rehabilitation process represents the other challenge of the pandemic situation in several countries, inscribed by a high proportion of limited patients. So these are my references as I use for my literature review. And at last, I would love to show my gratitude to the geriatric conference, the GERICON team, and especially the ExRx team for providing this great opportunity. And I'm really sorry for this hindrance which is created during my presentation. It just from kids. I'm really sorry for that. And please, if I get anything input for the improvement criteria and for further improvement, and I love to so that I get the opportunity to present over here, because I was very waiting for this to learn such type of specifically geriatric population and with a combination of COVID-19. Thank you so much for this providing this opportunity to me. Thank you so much. That's also from my side.
Nice. We'll move on to the juries for
Yes,
the
sir.
question and answer session.
Very good evening. That was a very good presentation.
Thank you, sir. Thank you so much.
That was a good innovative idea on making the geriatric population on how they are reacting to the COVID-19 is an important issue in this scenario. First of all, I appreciate you for taking this as your study.
Thank you so much, sir. Thank you so much.
So I just have only one query.
Yes, sir.
On your methodology on collecting the systematic reviews of the literatures, did you select any criteria like you have took only RCTs or case studies or case series? You have 3 literatures. Is that how many cases they have to taken for the study?
So both our studies, first study was done only in the ICU patients. They took the patient approx 65 to 70 patients, because they take the 70 patient, but 5 was like a post-COVID syndrome. So they included a 65 patient. Another 2 studies take the 50 patients in their OPDs.
Oh, very good. So, but you haven't considered any case studies or case series or any other cohort studies and all?
No, sir, I'm not concluded in my study as a case study, but those I took the articles. They directly work on. I can say that these are the studies, are the RCT studies.
Okay,
They done
okay.
work on over the patients.
Yeah, very good, ma'am. Congratulations.
Thank you, sir. Thank you so much, and it's a great pleasure to have you, sir, once again over this platform in this whole pandemic situation, sir. Thank you so much.
Yeah, I have one more question.
Yes, yes.
Yeah, as you had, as Saras asked, was there any excess protocol in COVID-19 patient as per your review? Did you find any review, like a protocol, like excess testing protocol after this post-COVID syndrome?
Yes, sir.
Have you mentioned this thing in your articles or review? Because that is very important, because after ICU, now we have to concentrate on the rehabilitation. So
exactly.
So have you mentioned any articles regarding that?
Yes, in my conclusion, I saw that there are many advanced approaches, which I can mention over here in this query, because they are using basically the dementia. The first was after the post-COVID-19, and I can say the in geriatric population, there's a psychological variance, a psychological disturbance, which is mainly seen in the normal age also, but this pandemic situation, they also it's a common problem which they face. That was a dementia and termed as a senile dementia, because it was for the specifically used for the geriatric population. And the protocol was like they give the sleep hygiene protocol. Another was like they using the CS modalities. Another most foremost like they have the active movements, or I can say active exercises, which is preferred for their psychological barrier. Another for the active range, because COVID-19 is in an ICU phase that took the patients. So they are in a very I can say in a rest position. They have no movement, they have no exercise, they have a loss of psychological barriers, and they have a physical problems, because they are 1 to 2 months continuously they are now bedridden patient. So general exercises with the active and passive, especially the breathing exercise as the COVID-19 requirement. So there are some protocols which they use there.
Yeah, what I'm trying to say is try to concentrate more on exercise protocols like post-rehab after post-COVID syndrome. Okay, thank you.
Thank you so much, sir.
Yes, madam, it was a good attempt. This is Dr. Srihari here.
Yes.
So I saw that you got only 3 literatures, right?
Yes, so basically specifically for the geriatric population, sir.
Okay, probably if you had searched with in the sense of flexibility, having more flexibility, you took only physiotherapy journals, is what you mentioned in
Yes,
your
yes.
inclusion criteria. If you had kept it a bit relaxed, probably you would have ended up in more number of articles, because physiotherapy related articles may be published in some other journals as well. So that could be one of the ways in having more number of articles, because only with 3 articles we can't conclude much. That's what
Exactly, sir.
I presume. Otherwise,
Definitely, sir, I work on it.
yeah, fine. Thank you.
Thank you so much, sir. Thanks a lot, sir.
Yeah, the presentation was actually good. I just have one question.
Yes,
Yeah, sir said correctly that you should have looked into more vast review of literature, because when we go into a review of literature, we consider it to be the second highest level of evidence. So looking into 3 or 4, 5 articles for review of literature may not suffice the need. Okay? Second, I just wanted to ask you that what do you ultimately conclude? Why did you do this literature or this review of literature on this specific topic, like
yes,
COVID
sir.
in geriatric population? So why did you choose this as a topic for
So
review
the
of
first
literature?
and most foremost thing that I would love to know about the geriatric population, what was the protocol, how to approach, first thing. Second, because the pandemic situation going on, and the patient I saw in geriatric population, they are always subside by the people, because they are considered as this is the age, so it's going to be happen in a physiological process. But the COVID-19 impact was great over the geriatric population. So I, from my knowledge, I want to uplift my knowledge, I want to improve my more knowledge, and I also want to create the awareness among my friends. As I'm talking to friends, they are always have some kind of a specific protocol, and they have I can say they have some age to not go for the burst in the geriatric population. They are not thinking about what the specific protocol in the COVID-19. So I just get to try it, and just I collect some articles and do it this literature, and I learn a lot of things. In all of this, I mentioned about the senile dementia. Before this, I never know about that. I know about the dementia, but I nothing know about the senile dementia. So I got to about this. Like what was the specific protocol for the COVID-19. That's why I choose this topic, sir.
Okay, thank you.
Thank you so much, sir.
Any more questions from the juries? Okay, it was a good attempt, Harshika.
Thank you, sir. Thank you so much.
With this, we are completing the presentation under UG category. Now we'll be moving on to the PG category presentation. The first presenter under PG category, sorry, with registration number 2021 000009. The title of the study is The Effect of Otago Exercise Program and Ball Exercise Imbalance Impaired Younger Older Adults. I hope the presenter is ready.
Yeah, good afternoon, sir. Am I audible?
Yeah, you are audible.
Good afternoon, everyone. The topic of my paper presentation is Effect of Otago Exercise Program and Ball Exercises in Balance Impaired Younger Older Adults. Introduction: Geriatric physiotherapy is a branch of healthcare system with elderly people by disease prevention, diagnosis, treatment, and problems specific to aging. Elderly is defined as being 65 years of age or older. It can be classified into 3 groups: young old, between the age 65 to 75, middle old 75 to 85, and old greater than 85 years. So it will provide the knowledge regarding the health problems which are particularly experienced by a group of elderly. And this knowledge will help the physical therapist in understanding the principles and perceptives that come into play when caring for aging, and even sometimes altering outcome through preventive measures. WHO defines healthy aging as a process of developing and maintaining the functional abilities that enables well-being in older age. The healthy aging pathway corresponds to lifelong processes building and maintaining intrinsic capacity and living in a functional independence within our own surrounding until the end of the life is the most favorable outcome. So the United Nations General Assembly declared 2021-2030 the decade of healthy aging, and it is a main strategy to achieve and support actions to build a society for all age. Balance is defined as a state of equilibrium in which body's center of gravity lies within the base of support. There are mainly two types of balance, static balance and the dynamic balance. Dynamic balance is the balance required to maintain the body's center of gravity when we are moving or reaching. Static balance means it is required in maintaining the body's center of gravity during quiet standing or sitting. Muscle spindle, Golgi tendon organs, and the joint capsules, mechanoreceptors provide information about joint positions of the movement. Proprioceptive acuity will declines with the normal aging, as well as several pathologies to interfere with the proprioception, which include peripheral neuropathy and degenerative joint disease. Loss of balance, it is a very common characteristic among aging population. It occurs when the COG falls out of the base of support. Exercises to improve the muscle strength and balance will help in the fall preventions in elderly population. Lack of exercises, fitness, nutrition lead to the gradual decline in the muscular strength and the functional capacity. This results in fall in elderly people. Otago exercises, it includes all the components of improving balance, strength, and functional capacity of elderly subjects. It is recognized by the Center for Disease Control and Prevention as an evidence-based fall prevention program. This is a home exercise program. It includes 12 balance and 5 strengthening exercises. And the term BOSO, it stands for both sides up. It was designed for the balance training and plays a very important role in the balance and improving the functional fitness. So the purpose of my study is to compare the effect of Otago exercise program and BOSO exercises program on young elderly people having impaired balance. Need of this study. It is to find out the effectiveness of Otago exercise program and BOSO exercise program and impaired young balance older adults. Most often, elderly people has problem with the reduction in the muscle strength, vestibular loss, contribute to the impaired balance. Loss of balance is a common characteristic of aging population. Otago and BOSO exercise focus on musculoskeletal rehab, and there is a lack of literature support the comparison of Otago and BOSO. So this study investigates the efficiency of improving balance with the help of Otago exercises and BOSO exercises. Objective of the study, to compare the effectiveness of Otago exercise program and BOSO exercise program on impaired among younger, older adults. Materials and methodology. Study design, it was a comparative study, study population elderly people. Sample design is a purposive sampling study setting old age 4. Then sample size is 30. Study duration, it is 2 months. Materials, chair, BOSO pen, pencil, paper, stopwatch, inch tape. Variables, dependent variable, it's a balance, and independent variable Otago exercise program and BOSO exercise program. Methodology, in that inclusion criteria, subjects willing to participate age between 65 to 74 years, subjects doesn't have any CNS, visual, hearing, and orthopedic disability. And exclusion criteria, the subjects with underlying diseases such as incontinence, sleeping problem, having severe visions or hearing impairment, recent lower limb surgery or injury. Outcome measures, mainly time up and go test and Berbalan scale. Study procedure, after obtaining ethical clearance of 30 subjects, were selected on the basis of inclusion criteria and randomly allowed into 2 groups. Then subjects were assessed to the performer and informed consent was taken. Time up and go test and Berbalan scale has been conducted pre and post. Based upon the inclusion and exclusion criteria, they were divided into 2 groups, Group A and Group B. Group A will be subjected to the Otago exercise program. It includes backward walking, sideways walking, one leg stand, toe walking, and sit to stand. All these exercises were done initially with support. Later, it was progressed without support. Exercises are performed for 30 minutes. Each set of exercises was given for 5 to 8 repetitions with a rest period of 2 minutes. Group will perform BOSO exercises, unilateral heel raise, marching, knee bend, split stance with the torso rotations, and one leg stance. All these exercises were done initially with the support, then it was progressed to without support. Here, exercises are performed for 30 minutes and each set of exercises was given for 5 to 8 repetitions with a rest period of 2 minutes. And review of literature, I have collected from the 10 articles to make this paper. Thank you.
Moving on to the juries for the
Akila and India, very good evening.
Very good evening, sir.
Before going to the question session, I just want to give you a small advice. You have to understand that PowerPoint is different, Word is different, right? You cannot make Word in the PowerPoint or PowerPoint in the Word. When we present a PowerPoint, you have to put some few points and then you start explaining, right? That is a best way of presentation. I'm not telling this was, but that is the best way of presentation. When you do the presentation the next time, please make it more visible to everyone, right? When we are presenting in the general public, like face-to-face presentations, the font size of at least 30 or 28 should be visible for even a person sitting 10 feet distance, 12 feet distance. Okay. Okay. So this is general advice for you. So you are going. You have selected. Did you completed this study or it's ongoing study, ma'am?
No, sir, it's ongoing study, not completed study.
Okay. So because you have not put any results, conclusion, discussion, you have not done, right?
Yes, sir.
So you have did only till the methodology, right?
Yes, sir.
So how you identify the younger old adults with the balance impairment? Do you have any strong balance test when you are including in your study?
Sir, as the literature says that elders age is starting from the 65 years or older, above 65. So the articles are saying that when a person enters 65, there is a very great difficulty in their balance, etc. They are facing very difficulty for the balance and the fall, etc. Very common when a person reaches around 60 plus or 65. So I just taken these exercises to see when I'm giving these exercises to those category of people.
Yeah, that's I understand. But when you are including your participants in your study, did you identify whether how much balance deficit they have got? Did you use some tools to assess that?
I have used this work balance scale and TUG as a pre-test to rule out how much
so you
balance issues are there.
Work balance scale and time up and go test.
Work balance scale.
So what is the minimal score they have to reach so that they will involve in your study? Did you have anything like that?
No, sir.
Okay.
Minimum.
Okay. Thank you. It was very good presentation.
Thank you, sir.
Yes, madam. Dr. Srihari here.
Yes, sir.
So what do you call this? Is this a pilot study or what is it?
It's a comparative study, sir.
Okay, comparative. But see, for anything, just deciding a sample size, did you have any methodology you used for deciding the sample size of 30 or it was a...
So through the mother study article.
Mother study article, you got 15 as this thing or arbitrary number? You are taking an arbitrary number to complete that one.
No, sir. In the studies, it says that 30 samples has taken. In that, they are dividing into 15.
Okay, there is a way of deciding the sample size. So that is the reason I asked you. And okay, and you told that random allocation. This thing one point of time you told you randomly allocated, and another time you told it was a purposive sampling. Which one is correct?
Sir, after ruling out through, after taking 30 samples, then randomly we are dividing into group A and group B.
Okay. Fine. And what about male and female? All both are included here?
Both, sir.
Fine, madam. Thank you.
Thank you, sir.
Akila, just wanted to add one more point. As per your outcome measure, fall efficacy scale can be included. Fall efficacy scale. Why you have not included that?
We can be included, sir, but I had taken this two, TUG and BBS.
Okay, fine. Just speak to your guide whether it can be included or not. Okay, and take care of your sample size as Sarah's already mentioned. Okay. Okay.
Yes,
thank
sir.
you.
Any more questions from the jury?
No, sir. We'll move to next.
Okay. Thank you, Akila. It was a wonderful presentation.
Thank you, sir.
The next presenter. The next presenter under teaching category, register number 2021 000007. The title of the study is The Effectiveness of Otago Exercise Program in Reducing Falls in Elderly Living in Old Age Home. Can we start?
Yes, sir.
Yes.
Okay, okay. Okay, you listen for the buzzer, okay?
Good afternoon, all respected dignitaries, delegates, and dear physio friends. I would like to thank Sri Anjaneya College of Paramedical Sciences and the Exercise Testing and Prescription Organization for hosting the program. Now it's my turn to present, and the topic is effectiveness of Otago exercise program in reducing falls in elderly living in old age home. One of the major challenges that the elderly population facing is balance. As we age, every system in the body gets deteriorated. And when it comes to balance, the only remedy we can apply to improvise is increasing the balance. I have selected Otago exercise program as a remedy, which not only increases the balance, but also it works with lower extremity strength, flexibility, and reaction time, which sums up and results in fall prevention in elderly. The Otago exercise program consists of a set of leg muscle strengthening, balance retraining exercises, progressing in difficulty, and a working plan. My aim was to study the effect of Otago exercise program in reducing falls in elderly living in old age home. The objective was to study the effects of Otago exercise program on tendencies to fall among group of elder individuals living at rural old age home. To study the effectiveness of Otago exercise program in affecting the tendency to fall by comparing with a control group of elder individuals. The study design I selected was pre-test, post-test experimental design, and the study setting was Anjaneya Charitable Trust Old Age Home at 5 km. Sir, please next slide. I have selected 30 samples from a group of geriatric population by simple random sampling method, and each subject was about 65 years old with history of fall and able to walk a minimum of 10 meters long. Any subject with a history of lower extremity fracture in last 1 year or with poor visual and auditory sense or doctor recommendation discouraging participating in any type of physical activity was excluded. This is the flowchart showing procedure. I will explain detail in next slide. Sir, please. This is some of the exercises where I given in the old age home. So next. The procedure was 30 subjects were divided into two groups of 15 each, control and experimental group respectively. The experimental group was provided with Otago exercise routine after taking the baseline values. The exercises included lower extremity strengthening exercises, balance retraining exercises. The lower extremity strengthening exercises included knee extensor strengthening, knee flexor strengthening, hip abductor strengthening, ankle plantar and dorsiflexor strengthening. And the balance retraining exercises included 12 tasks, which includes knee bending, backward walking, walking and turning around, sideways walking, tandem stand, tandem walk, one leg stand, heel walking, toe walking, heel toe walking backward, sit to stand, and stair climbing. The subjects were recommended to walk at least 30 minutes, which may be divided into 3 sections of 10 minutes walking. The Otago exercise section consisted of 5 to 10 minute warm-up, 30 to 40 minute strength training, and balance retraining exercises, and 5 to 10 minute cool down for 3 times a week for 6 weeks. Whereas in control group, the subject will continue their daily routine and no training will be provided. The outcome measures was bar balance scale, fall efficacy scale, 30-second chair stand test. After 6 weeks, follow baseline measurements are taken. And now we can look at the comparison of pre and post test values of bar balance scale. Then the next slide. Comparison of pre-test and post-test fear of fall in experimental and control group. Then comparison of pre-test and post-test chair stand test in experimental and control group. So the result was experimental group gained significant improvement in balance, lower extremity strength, and reducing the incidence of fall, and was proven with statistical analysis. The discussion part, majority of falls occurs because of multiple interacting factors, but leg muscle weakness and impaired balance contribute to most falls. Otago exercise program improved participant strength, balance, and confidence, helped to maintain confidence in carrying everyday activity without fear of fall, And the limitations I faced during my study was unequal number of subjects in demographic population and COVID pandemic. I would like to show my gratitude to host for organizing this section and GERICON. Thank you, juries and my friends for listening. Thank you.
Session open to the juries, open to the forum.
Yeah, very good presentation.
Thank you, sir.
Like you said, really Otago exercises does wonder in elderly populations. These exercises not only improve balance but also improve mobility also in elderly people.
Yes, sir.
So I have only one question. You have taken the participants who had a history of fall.
Yes,
So
sir.
how many times did they fall in that 1 year? Like last year?
Sir, history of fall with one time, sir. So
one time.
yes.
So that has to be also mentioned here in the inclusion criteria so that you are able to identify how much the patient have a balance deficit. The
Okay,
second
sir.
one is in the limitations, you put COVID pandemic. All the patients are inpatients, right? They are in the house, right? Old age home.
Yes, sir. But I
How
have,
COVID pandemic affects that people?
sir, I have problems to meet there, sir, due to COVID,
Then
sir.
you have to design your study like that. Whenever you are meeting, you have to do that. Okay, very good presentation.
Okay, sir. Okay, thank you, sir.
Yeah, madam, good presentation.
Thank you, sir.
So only two questions. One is you told it was 3 times a week and for 6 weeks. Are you
Yes, sir.
following the patients after 6 weeks?
No, sir.
No. It is good, no? If you have got any, in the sense if the patients are still there, it is better to have a long-term follow-up. So just a suggestion. And so all these sessions were supervised sessions. Isn't it?
Yes, sir. Yes,
And
yes, sir.
was there any home advice given, home exercise program, if anything between the days?
No, sir.
No. Okay. Fine, madam. Thank you.
Thank you,
Yes, I do have one question.
sir. Okay, sir.
What were the precautions that you took while giving these Otago exercises in elderly? Because they already were at risk of falling.
Yes, sir.
So what were the precautions that you took from your side so that you do not cause any harm to the participants of your study? Because they all were elderly, right? They already had one episode of fall in last 1 year.
Yes, sir. Sir, Otago exercise program, sir, first exercises are given with support, sir. So I supervise the program. Then only once they get more confident to do the exercise without support, then only I have proceeded to the next level, sir. Supervised sections are carrying out. So.
And did you have any dropouts?
No, sir.
There were no dropouts. How many subjects did you take for your study? Sorry.
30, sir. 15 each. 15 control and 15 in experimental.
Okay. And why did you select specifically only those elderly who had only one episode of fall? See, one episode of fall in last 1 year can be because of any cause. It is not necessary that it may be because of balance or right. So what was the purpose of taking subjects only who had fall once in last 1 year? Was there any specific reason behind it, or was it just?
Sir, we are excluding the people with any fracture or any other diseases in the last years. So once they get frequently falls, they definitely they show some of the fractures or like any other problems. So.
But see, what I believe is that just one history of fall once in a year may not correlate anything with like balance affected, or because it may be a normal fall, right? If you ask me, even I at this age must have fallen down once or twice in last 1 year. So how do you correlate it with affection, or because you are doing this Otago exercise to prevent falls by improving? What are you improving by giving Otago exercises?
Sir, balance, then lower extremity strength.
Yeah. So how could you conclude that that one fall in last 1 year was because of balance problems or weakness in the lower legs? Are you getting my point?
Yes, sir.
Right. Because fall can be because of many reasons.
Yes.
Okay. I may be walking and there is an uneven surface and I may have fall. Right. Or I slip on a surface and I have a fall. So first you need to identify those subjects who actually had fall because of balance problems and lower extremity weakness problems. Okay.
Okay. Okay.
So
Thank you.
yeah, for me, according to me, taking only one history of fall in last 1 year probably may not suffice the actual outcome of your study.
Okay, sir.
Okay.
Okay.
Thank you.
It was a good presentation. How was your sample size determined?
Sir, according to review of literature, sir.
As we have discussed, any software was used for determining sample size, and how like allocation was done? 15-15, right?
Yes, sir. Simple random.
Okay. Thank you.
Thank you.
Any more questions from the jury?
We'll move on to the next.
Yeah. Thank you, everyone. We'll move on to the next session. The next presenter is register number 2021 00000006. I hope the presenter is ready.
Sir, I have one query that my registration number is 16, not 06, I think.
That is a common registration number. Your registration number for paper presentation is?
Okay, sir. Thank you, sir.
So just going to the title of the study, the effect of worksite physical therapy intervention on neck pain among office workers. So you hear a buzzer. Okay, once you hear a buzzer, you can start with the session.
Okay, sir. Okay. Hi, good afternoon, everyone. Respected judges, hosts, and my dear friends. First of all, I would like to thank Sri Anjaneya College of Paramedical Sciences and the exercise testing prescription for hosting such a beautiful session. My topic for e-paper presentation is effect of worksite physical therapy intervention on neck pain among office workers. Since I have only got 5 minutes, long story short, I have selected this topic because of a particular reason. As in today's hectic schedule, nobody is able to do any exercise regularly. Even in today's morning session, Dr. Vijay Selvan sir mentioned about the same. I think everyone listened to that. Neck pain is common in office workers, especially those who work with computers, who keep sitting from morning till evening in same position. They may neglect the problem when the pain starts at the beginning, and it may increase gradually. Then they consult any medical practitioners, ends up in painkillers. Obviously, we know that it has its own side effects. So that I have decided to select this topic. We need to focus more on physical rehabilitation rather than any medication, where physiotherapy can do miracles with no side effects and good results. The problem is that most people are not aware of it, and we need to give awareness in public to change the mindset of the public. This study was done during the working hours. That is, employees may get time to do this while at work, and no extra time would be taken from them while they are at home. But they can follow that exercises while at home. All they need to do is to do few steps of exercises in between. This would help to maintain a healthier workforce and would benefit from reduced direct costs associated with healthcare expenses. It also increases employers' productivity, reduces absenteeism, and increases morale. Sir, next slide, please. And the study design is experimental type of study and conducted among office workers in Indo-American Hospital Wycombe and Indo-American Hospital Chamanagiri. Subjects were selected by random sampling method. A total of 30 subjects were selected from the group of employees and divided into 2 groups, that is 15 each in experimental and control group. The main criteria while selecting the employers included that they were working at least for past 1 year, and below 50 years and has a history of neck pain for more than 3 months. Any cases of disc prolapse, trauma, pregnancy, post-surgical treatment at neck was excluded. Experimental group consisted of 15 subjects and provided with a set of exercises of 10 to 15 minutes for 3 times per week for 6 weeks. Sir, next. Yes, sir, this slide. Baseline values were taken at first, and the set of exercises was given after 6 weeks. Baseline would be measured again. The exercises included, sir, next slide, please. That I have included the photos here. Next exercises included like chin tucking, shoulder striking, shoulder rolling, scapular retraction, postural correction, and ergonomics in standing and while sitting. Stretching exercises was also included. Control group received no intervention, but was advised to stay physically active during the period of study. Outcome measure was done using neck disability index and was scale, and the result was proven with statistical analysis. That 6-week strengthening program directly benefited in decreasing the pain in office workers. Limitations like time availability of employees at working hours, and due to COVID pandemic, the schedule of the employees was very tight. So I had to find time in between. They have a hectic schedule. We all know that office people are never free. So I was waiting every time to get them for my treatment sessions. This study has a significance that exercise as working hours would not make any loss of employer's time, and employer also would not get loss because it is during the rest time, or just stretching and strengthening exercise would not take any of the time. So that I conclude my presentation, and thank you for listening, and I'm ready for questions, please.
Yes, open to the judges for the question answer session.
Yeah. Your number is 16 or 6?
6, sir.
6, okay. So it was very good one, and so you have selected the office workers in your hospital. So
Yes,
what
sir.
type of work they are doing, whether they are using computers or paperwork?
Sir, office workers, I mean that they are using mostly computers and writings.
Computer and writing. How about the postures? Posture you haven't mentioned there, right? Only exercises you have told. What about the posture in their work?
Sir, I have given exercises for posture corrections, strengthening exercises, and they have to look at them. That is that biofeedback mechanisms. I have said them, and I brought them to the department, and I just showed them this is the way you should stand, or this is the way you should sit, and I followed up each time, and I just corrected the way they are sitting, they are standing, they are walking, and these things I just reminded them, and I gave them my WhatsApp number, and they just text me when they are free, and I will give the advices, or they video call me. I will give the advices to them.
So what type of neck pain do you include? Whether what type of neck pain of all these office workers has got?
Sorry, sir.
What type of neck pain you have included in your study?
Sir, neck pain due to their postures, that is muscle tightness and all. Those type of neck pains are
mechanical neck pain you have included?
Yes, sir. Neck pain.
Any other conditions like spondylosis or?
No, sir. Those are excluded. I have already said that in my exclusion criteria, sir.
So you told the patient have already having neck pain, right?
Yes,
so
sir.
are they are under treatment or not under treatment?
They were not under treatment. They were not actually. I was surprised that they were unaware of that, because they say that we have neck pain, we will do apply some ointments, the pain subsides, and they will go like that.
Thank you. Nice.
Okay, sir.
Yeah, good afternoon. It was a good presentation. A few questions. One is why didn't you have any lower age limit? You told the age is only 50 years. Why didn't you have a lower age limit?
So basically, I selected from all categories, but the age should not be more than 50 years. That was my criteria, because I have
Just a minute. See, the thing is, whenever you are doing any research, you have to make it very clear which age group you are concentrating. So if it is only less than 50, somebody who may be a person who has just graduated and he may be around 22 years or something like that. So don't you think there will be a vast difference between 22-year-old and 50-year-old?
Yes, sir.
So it is better to have a lower age limit. So that was my
Sure, sir.
opinion.
Yes, sir.
And
That was my
at the
mistake.
same time, same time, see, have you taken into consideration the working hours? How many hours of work they are doing to make the baseline even?
Yes, sir. The actually before COVID pandemic, they had to work only for few hours, like 6 or 7 hours. But after that, when employees got a tight schedule, they have to work even 8, 9 hours. So it also reflected that they have much stress in their work, and
No,
they
just a minute. Again, wait. The thing is, all these things you have to define prior to your study, is what I am telling. So, number of hours of work they are engaged in. So, that also has to be considered. And any other physical activity they are already into. If maybe somebody is practicing yoga, somebody is into gym. So, are you excluding these people? You have not specified. Have you taken
sir,
any? Have you
yes,
taken
sir. I
any
have taken.
permission?
Yes, sir. I have considered them. I have asked them, but most of them, everybody knows that, but nobody is regularly doing anything.
Okay, fine.
And I have included that in my study, but I couldn't include that in my presentation because much bigger slides would be slide number would be increased. That's why I couldn't include that.
Sure. And only another just concern was, have you taken permission to use neck disability index?
Yes, sir.
Have you taken permission? It requires, right, from the author. So consider these things while you are designing future studies. Thank you.
Okay, sir. Thank you, sir.
It was a good study. I just have to add one suggestion. As your employees are all computer workers, right?
Yes, sir.
So you can also add your eye exercises, which can be included.
Sure,
so that will also cause strain eye. So that can be implemented, like an RCT can do in future, eye plus neck as experimental and control only neck exercise and see which is
sir.
effective. Okay,
Yes, sir.
thank you.
Sir. Thank you for that, sir.
Thank you, juries. Can we move on to the next session?
Sir, I just have a question if the participant is on.
Yes, sir. Please.
I just wanted to know what new innovative thing did you find out after doing this intervention or this study?
Sir, it's not much newer, but I found that our society doesn't know much about physiotherapy. That is the thing that I know about that. Nobody is aware of the physiotherapy. What changes that physiotherapy can give them in their life. Because after my treatment, there was a very good change. Then, and after that, many employees from the same hospital came to me. I just treated them for free, and I just give them advice that whenever someone says there is pain, you just don't go to a medical practitioner. Rather, they can come to a physiotherapy clinic or any hospital. That can make a good difference in them. And every time medication would make our internal organs worse also.
Okay, sir. Okay, thank you.
Thanks, sir.
Thank you, judges. Thank you, everyone. We'll move on to the next presenter with the registration number 2021 00000008. Judges, please note 2021 000008. The title of the study is Effectiveness of Vibration Therapy and Myofascial Release of Subscapularis on Pain, Range of Motion, and Disability in Patient with Adhesive Capsulitis, a case study.
Good afternoon to all. So my title is Effectiveness of Vibration Therapy and Myofascial Release of Subscapularis on Pain, Range of Motion, and Disability in Patient with Adhesive Capsulitis, a case study. So now the introduction part. The shoulder joint is a ball and socket synovial type of joint. As a medical world suggests that adhesive capsulitis conditions occurs when the shoulder when the shoulder capsule becomes inflamed, and this inflammation is causes tissue degeneration, short joint capsule thickening, diminished glenoid cavity volume, and adhesions to develop between to the joint surfaces. That shoulder become painful to move, and movement of the shoulder joint is restricted. It occurs in 2.2 to 5% of general population, mostly seen in 50 to 60 years, and mostly seen in women. So the case presentation is a 55-year-old female housewife has pain in her left shoulder region in last 1 month. Patient is having difficulties in overhead activities like combing hair, ADLs like bathing. The pain is gradually increased and intermittent in nature. The pain is increased at night. Patient had 6 on NPRS pain in difficulties in ADLs and 3 on NPRS during rest. After the proper investigation, she was diagnosed to have adhesive capsulitis in her left shoulder. Then the patient came to physiotherapy OPD. She has following findings. On the postural evaluation, patient has elevated shoulder at left side. On the palpation, patient had tenderness grade 2 at anteromedial aspect of the shoulder. Active and passive range of motion of shoulder flexion, extension, abduction, external rotation, and internal rotation were painful and restricted. Anfield was abnormal tissue stretch. Capsular pattern was present, that is abduction, external rotation, and flexion is restricted. Manual muscle testing of shoulder flexors is grade 3, shoulder extensors is grade 3 plus, shoulder abductors grade 3, shoulder external rotation grade 3, and internal rotation. And the intervention part is a 4-week protocol on alternative basis will be given to the patient. The vibration therapy was given with the help of mechanical vibrator at a frequency ranging from 50 to 150 Hz for the 30 minutes of duration with 2 seconds of rest in between each repetition, 1 session per day. And subscapularis myofascial release, patient position was supine lying, therapist position standing beside the patient, and procedure was the subscapularis was palpating axilla using the pincer grasp by the going deep till reaching anterior aspect of the scapula. The identification was muscle was confirmed by the feeling the contraction while the subject internally rotated to the shoulder. After the trigger points were then treated with the myofascial releasing technique with combination of manual pressure and slow deep stroke to the subscapularis muscle for the 7 minutes. I have taken the outcome measures for this study is the NPRS, that is numeric pain rating scale, PADI, that is shoulder pain and disability index, and range of motion that is assessed by the goniometer. And the conclusion was of the study is the vibration therapy and myofascial release of the subscapularis had effected in improving range of motion, muscle strength, and reducing pain in the patient with adhesive capsulitis. The rehabilitation protocol used in this study improves the shoulder joint function. Thank you.
Open to the forum for questions.
Yeah, it was a very good presentation, good title also. The
Yes,
vibration
sir.
therapy,
Thank you.
we are just started using, I think, the musculoskeletal part also. How long this you are giving any vibrations to the patient?
It's for 30 minutes. Rest period is 2 minutes. 4 weeks of protocol.
How long? 4 weeks. Is it daily
yes,
or
sir.
alternate days or?
Yes, sir. 3 days per week.
3 days per week. Okay.
Yes, sir.
So
On
how you
alternative
assess the
days.
muscle strength for this patient? Which muscle strength you have evaluated?
Subscapularis muscle, sir, on the axilla.
Okay, subscapularis muscle strength. How you assess? How you evaluated?
Subscapularis muscle was palpated in the axilla using the pincer grasp by
No,
going
you
to
put you have shown that there was improving range of motion muscle strength, right? The subscapularis muscle strength was improved.
Yes, sir.
How you measured that subscapularis muscle strength? Okay, how good the pain was reduced? How much the pain was before and how much the pain was after the treatment?
Sir, pain after the treatment, the NPRS score was 6, and after the treatment, the NPRS score was 2.
Two, very good. Oh, so there was a great improvement in the pain, right? Reduction of the
Yes,
pain.
sir. Yes, sir.
Thank you, Mr.
Yeah, good afternoon. So one thing is, how long did you follow up with this patient, madam?
Per week, sir.
1 week.
1 week, yes, sir.
Only 1 week. What was the improvement in the muscle strength? MMT, what was the final reading?
Sir, final grading was the 4 or 4 plus.
What do you think contributed to the increase in the muscle strength? No, it will say you have given vibration therapy and myofascial release.
Yes, sir. By giving the vibration therapy or myofascial release to the subscapularis muscle, sir.
Okay, but how do you think it would have helped? Is there any physiological background that vibration therapy can increase the muscle power or myofascial release can increase the muscle power?
No, sir. It's only increase the range of motion of the patient.
Okay, then what do you attribute the muscle power, increase in muscle power to?
Sorry, sir.
Fine. Thank you.
My question is, what is the name of the device used, vibration therapy device?
It's a mechanical vibrator therapy, sir. Exactly,
Okay.
I didn't.
What is the frequency given for this?
50 to 150 hertz.
Okay, so, fine. Okay. So you're not aware of the name of the device you have given? It's just simple mechanical chest vibrator or some other thing it is?
Yes, sir.
Okay, thank you.
Hello. 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 Am I audible?
Yes, sir.
Yeah. Was there any conventional therapy given to these patients?
Yes, sir.
So-
Moispec is given to the patient before and after treatment.
Okay. Anything else that you gave apart from
Yes.
Moispec, vibration, and myofascial release?
Yes, sir. Ultrasound.
Okay. And other than that, can you just brief me about the whole protocol of the patient? Quick points, at least. Myofascial release, vibration, ultrasound, Moispec. Anything else?
Ultrasound, Moispec. And the sir, for strengthening program is the TheraBand exercises for of yellow band.
Okay, then you should have mentioned this in your study that you also included a conventional therapy,
Yes,
right?
sir.
Combined with myofascial release and vibration therapy. Probably this TheraBand exercises that you implemented could
Yes.
be one of the reasons for getting improvement in the strength, because you are taking strength as an outcome measure.
Yes, sir.
But you have not put anything as the treatment protocol which can improve strength.
Yes, sir.
Right. So if you have mentioned that conventional therapy was given in the form of TheraBand exercises or resisted exercises using TheraBands, probably you could have justified the question that why there was an improvement in the strength of the muscles after giving vibration and myofascial therapy, right?
Yes,
Because
sir.
it was combined with conventional therapy in the form of ultrasound and strengthening exercises using TheraBands.
Yes, sir.
Okay.
Okay, sir.
Thank you.
Thank you, judges. Any more questions? Can we move on to the next? So our next candidate is with registration number 2021 000010. The title of the study is Predictors of Agility in Community Dwelling Elderly Living in and Around Mangalore. Hope the presenter is here.
So can I start?
Yeah, are you ready?
Yes, sir. Yes, sir.
Once you hear the buzzer, you can start.
Okay, sir. Good afternoon, everyone. My topic for the paper presentation is Predictors of Agility in Community Dwelling Elderly Living in and Around Mangalore. The introduction falls in their complications. They are a major issue in the elderly since they are a major cause for hospitalization, which leads to an immense burden on the healthcare system, as well as there is a reduction in the general functioning of quality of life. The causes of falls, they are multifactorial. It can be the intrinsic causes such as lower extremity strength, balance, or it can be extrinsic causes such as slippery floor or hampered, cluttered environment. So to assess various fall risk components such as stop and go pattern, change in direction, rotational movements, they were incorporated into the testing protocol. So which led to the development of testing protocols based on agility. So basically, agility is defined as change in body position while maintaining balance without loss of speed. So this definition was adjusted to the elderly by Young et al. As quickness in the systematic motion. So agility, it is associated with various physical characteristics such as balance, strength, cognitive components. So any decrease in them can lead to increased risk of falls. However, there is lack of evidence regarding the predictors of agility in community dwelling elderly in India. The need for my study. Agility is found to be strongly associated with fall risk in elderly. However, there is paucity of quality literature on factors across various domains associated with agility in Indian population. The participants for my study were community dwelling elderly of either gender, age group 60 years and above, who are independently ambulating in the community with no neurological, musculoskeletal or systemic pathologies which could limit their performance in the agility test. So the purpose of the study was to identify the strongest predictor of agility in community dwelling elderly, given the variables for the lower extremity extensor strength, balance, and reaction time. So the methodology was 22 community dwelling elderly were recruited. Agility was tested using agility challenge for elderly test, that is ACE test, and lower extremity muscle strength was assessed using dynamometer, balance using functional reach test, and reaction time using ruler drop test. So next slide, please. The agility challenge for elderly test, it basically has 3 components in it. The first component is stop and go patterns, wherein the markers are placed at 3, 4, 6.5 and 8.5 meters. And the second one, it has change in direction component, where there are 6 turns which they have to take. And the third component, which challenges the spatial orientation, wherein different color cones can be kept or different numbers, random numbers can be kept. So the participant has to go to the particular cone, round it off and come. So basically they have to follow an order which is given. So data analysis, each of the independent variables, they were individually correlated with agility, and linear regression with agility as a dependent variable, and each of the outcomes, either individually or in various combinations, were performed to identify the strongest predictor of agility. So the results, there was a moderate positive correlation between reaction time and agility, whereas when compared to reaction time and other variables, that is lower extremity strength and balance, there were moderate negative correlation, but it was not statistically significant. A logistic regression showed that reaction time individually is a stronger predictor of agility, but when compared, when it was in combination with other independent variables, it showed that reaction time along with balance is a stronger predictor of agility. So these are my references. Thank you.
Open to the juries for the question and answer session.
Yes, madam, it was a nice presentation. Appreciate that you have used one objective measure, the dynamometer, which is a good outcome measure. And again, with one of your previous presenters, I asked the same question. Why have you kept only 60 years as the age inclusion criteria? Why not the upper age limit? We know that again, geriatric population may be divided into different age groups and all those things. Why have you not kept the upper age limit for your study?
So there are previous evidence, like the previous literature, which it had taken into consideration 65 to 75. So I wanted to check whether it still affects in the age group from 60.
Okay, but if you could have specified, no, 60 to 65 or something like that, you could have specified. So that was for your criteria, but you got around 20 patients, right? 20 geriatric population.
Yes, sir. For now, I've got only 20.
Which age group they belong to?
So they are from 60 to 73 I have got for now, sir.
to 73. Okay.
Yes, sir.
Okay, fine. And on what basis you selected only 20? You have got only 22 patients as of
20.
now.
Yes, sir, as of now.
But you are going to continue the study.
Yes, sir.
What is your calculated sample size?
Sir, it is 56.
56. So you are
Yes.
confident of reaching them.
Hopefully, sir.
Okay. And why are you terming it as in and around Mangalore with only
Sir,
55 sample size? And you are how can you tell that it is a cross section of Mangalore population?
Yes, sir, because the study area is located in Mangalore, the community outreach center. So I'm taking who are in and around that area.
Okay, okay. No, I understand that one. But if you tell that it is, so it means that it is a cross section of Mangalore, which
Yes,
it cannot be with just 55 number of individuals is what I am trying to tell. Otherwise, it is a good study. All the best.
Thank you, sir.
Yeah, I have only one query. So it was very good study. What was your conclusion in this? Why you are trying to do this study?
So this is basically to predict which is a better fall risk factor in the elderly in considering agility as a this one in dependent variable.
What is your conclusion?
So the conclusion was when it is taken individually, I had taken reaction time, lower extremity strength as well as balance. So when it is done individually, reaction time showed a better predictor. But when there were various combinations were done, it showed that reaction time along with balance showed a better predictor of agility.
Yeah, thank you. It's a wonderful study, Dennis. You finish and try to publish in some journals.
Yes, sir. Thank you, sir.
Thank you, judges. We'll move on to the next paper.
Thank you, sir.
So the next presenter is with registration number 2021-000004. The title of the study is The Role of Proprioceptive Training in Post-Operative ACL Injury Rehabilitation. I hope the presenter is here.
Yeah, yes, sir.
Yeah, okay. So we'll start with the buzzer, okay?
Okay, sir. Good afternoon, everyone. Today I am here, GERICON e-paper presentation 2021. My register number is 2021000021. Today I would like to say about my research topic. My research topic is role of proprioceptive training in post-operative ACL injury rehabilitation. As the first introduction, as we all know that the ACL injury is most common in non-sports person and non-sports person. After we getting the ACL injury rehabilitation, the proprioception of the knee joint will lose. We all know that the knee joint is a very complex joint. The joint consists of motor points and larger motor points, and there is a connection between the brain and the muscle. This connection makes the joint proprioception makes very good. So after getting the ACL injury, the proprioception will lose. So my study is aimed to enhance that the proprioception of the joint will regain. So the proprioception refers to the specialized variation of the sensory modality of the test that encompasses static awareness and joint position awareness, detection of movement and acceleration, closed loop efferent activity. This that reflects response and regulate muscle. These all functions will lose after getting the ACL injury. So then the purpose of the study is the concept to encourage. The purpose of the study is the concept is encompasses that the encourage the proprioception of the knee joint. Aim of the study to investigate the role of proprioceptive training in the ACL injury rehabilitation. Then methodology is null hypothesis and research hypothesis, and the study design is pre-test and post-test experimental study, and the duration is 6 months duration. and the patients is randomly selected 20 samples according to the inclusion and exclusion criteria. These 20 samples were divided into two groups, Group A and Group B. The Group A consists of the normal physiotherapy intervention, and Group B consists of the strength training plus the proprioceptive training. That the group is experimental group. Then after the results and the progression be calculated by the outcome measures by using Cincinnati Knee Rating Committee scale and IKDC scale. The Cincinnati Knee Rating Committee scale, which consists of the 6 physical activity, and the IKDC scale is a type of questionnaire. According to these outcome measures, the last date of the month after the 3 weeks. After the 3 weeks, I checked and analyzed the statistical value. The same like after the 6 months. After the 6 months, I concluded, I reached, that means I reached the statistical analysis. When compared to the Group A and the Group B shows the significant results in the ACL injury rehabilitation. So that I concluded that the Group B consists the more and significant improvement in the rehabilitation program path. So after the 6 months intervention protocol, during this all statistical analysis and the data analysis about the pre-test and post-test of the IKDC and the Cincinnati Knee Rating Committee scale, the significant improvement, that means the significant improvement in the Group B shown. So as a physiotherapist, I strongly recommended that those who suffered the ACL injury those who suffered the ACL injury, the physiotherapist should recommend the strength training as well as the proprioceptive training. Everybody knows that the normal strength training and normal physical intervention is essential for the ACL injury rehabilitation. But also, every age we can strongly recommended this proprioception, because after the ACL injury, most of the patients may lose the balance, so that the fall prevention can reduce by using this ACL, using this proprioceptive training technique. So finally, I concluded that my research is to encompasses that the proprioceptive training is most effective in post-operative ACL injury rehabilitation. So, thank you.
Can you please go back to the inclusion-exclusion criteria, sir?
Okay, inclusion-exclusion criteria, which consists according to the grade and level of the injury. First, inclusion criteria means according to the grade and level of the injury, the history of post-surgical repair, symptom-free contralateral knee, recreational football players. Then excluding previous knee injury, arthritis, history of significant knee injury, presence of associated PCL injury, and meniscal lesion. These all were excluded and including according to the grade and level of injury.
So my question is that you have taken age criteria from 18 to 45 years and you have taken recreational football players. So did you find anybody between the age of 40-45 playing who is a recreational football player in your study?
Yes, sir. Sir, because the study is randomly selected. It was randomly selected.
But was there any participant who was above the age of 40-45 who was a football player?
Yes, sir. Recreational players. Because I was rehabilitated by 3 recreational players during that time.
Okay, sir. And how old was the surgery performed? You have taken the history of post-surgical repair. How old was the surgery done? Like how old surgery you took patients with? 1 year, 6 months, recent?
Sir, mostly I prefer after the 3 weeks. After the 3 weeks from the surgery.
Okay. What if the surgery was done 6 months back? You did not take those subjects?
Sir, okay. Actually I selected the past 6 months and 8 months, and 4 patients. Actually, 4 patients from after the 1 year. They have no balance. They have no coordination, and normal physical activities totally restricted.
Okay, sir. Thank you.
Thank you, sir.
Yes, Abin, just have only one question.
Okay, sir.
Do we give the proprioceptive exercises to the post ACL injury or surgery, or even for ACL injury patients also, can we give proprioceptive exercises?
Sir, you asked post-operative ACL injury.
Can we give proprioceptive exercises only to the post-operative patient, or for the grade 1, grade 2 injury patients also?
Sir, we can do on the both side, post-operative or non-post-operative. Because on my study, the inclusion criteria, grade and level of injury, because the post-operative patients almost getting grade, they are almost grade level 2. So that type of patients need definitely a surgery. So that type of patients only I are including in my surgery.
Okay, thank you, sir.
Okay, thank you, sir.
Yeah, you have selected in the sense your study involves population between 18 to 45 years. Nothing to do with geriatric population. But still you are presenting here. Any specific reason?
Yeah, sir. Actually, I included 80 to 45 years on my study, but the proprioceptive training is actually it's very good for the old age. Means if getting any 45 more than the 45 years individual getting ACL injury, we can definitely recommending the proprioceptive training, like single leg stands, backward walking. Actually, it's a simple kind of exercise that we can introducing to the geriatric patients.
Fine. So you have only 20 patients included, isn't it?
Yeah.
And you have followed, you told you have followed it for 6 months. 6 months? Am I right?
Yes, sir.
What about the dropouts? Did you experience any dropout?
Sir, during that time, I faced COVID-19 and lockdown, some kind of problems. Some patients are
not problem. How many dropped out of your study? Out of
sir,
20?
Nothing.
Yeah. Out of 20, were there any dropout?
Sir, actually, I collected more than 25. More than 25. Then I am recommending those 25 the same follow-up, and gradually some patients drop out from the intervention. They having their own personal matters.
No, sir.
They are not willing to taking.
No. In your research, you can't tell some patients. You should specify how many. In the sense, you should have a flow chart which has the details of all these things. So see if you can do it. Okay. Thank you.
Okay.
Thank you.
Okay. Thank you, sir.
Any more questions from the jury? Can we move on to the next presenter?
Yes, sir.
Yeah. Our next presenter with registration number 2021 00000005. The title of the study is The Relationship Between Development of Musculoskeletal Disorder and Aerobic Capacity in Healthcare Workers. I hope the presenter is ready. Arja, can you? Arja, hello. So
Hello, sir. I think she's absent. I think.
Okay, we'll move on to the next participant. So we'll be starting with our academician professional category. So our registration number 09, that is presentation number 09, category professional academician. Registration number 0000141. Study is the efficacy of task-oriented motor training versus multisensory training on gait, balance, and quality of life in participants with type 2 diabetic neuropathy. You will hear the buzzer. Once you hear the buzzer, you can start with your session.
Okay, thank you, sir. Good afternoon, and special thanks to the entire organizing team. And my title is The Efficacy of Task-Oriented Motor Training versus Multisensory Training on Gait, Balance, and Quality of Life in Participants with Type 2 Diabetic Neuropathy. Then move on to the introduction. The diabetic mellitus, frequently endocrine diseases and long-term complications that affect various organs as well as systems. And India has the highest number of diabetes with over 30 million people in the world. And diabetes neuropathy is the late complications of diabetes and prevalence that increases with age, and both genders are equally affected. Then peripheral neuropathy that leads to sensory and motor deficit with reduced their spatial and temporal variables of gait. That gait means bipedal, biphasic forward propulsion of center of gravity of the body that involve balance and coordination of muscles as well as human body. Then balance means ability to maintain center of gravity within the base of support, and it requires input from afferent receptor system, vestibular, visual, proprioception, as well as general extrasensibility. So here the task oriented motor training, that impairment oriented exercise intervention that to improve gait as well as balance. So and the second one, multisensory training, and it has improved functional mobility as well as balance. So limited mobility and balance impairment will reduce the independence of daily living and social roles as well as quality of life in diabetic neuropathy populations. So there are no studies done the effect of task-oriented motor and multisensory motor training on gait, balance, and quality of life in diabetic neuropathy. So and hence these exist a need for this study. So then move on to the reviews. These are the reviews, and move on to the inclusion criteria. So both genders equally, and age between 50 to 75. The Michigan neuropathy score is greater than or equal to 7. Then glycated hemoglobin level greater than 6.5%, and that diabetic diagnosis for at least 25 years. And the TUC score is less than or equal to 16 seconds and able to walk 6 minutes without support. And the exclusion, the patient had food ulceration, then retinopathy, hypo or hypertension, then autonomic neuropathy or other orthopedic and neurological disorders that influence gait and balance. Then patient had no experience with a similar gait and balance training during last 12 months of period. Then methodology, experimental study design, diabetic center in and around Trivandrum, simple random sampling, 52 subjects. So outcome measures, TUC, BBS, and Norfolk quality of life questionnaire. So administration of procedure. So here 52 subjects that divided into 2 groups. So the written consent will be obtained from the subjects and baseline measurement conducted and again assessed after 3 months. Group A and B received task-oriented motor training and multisensory training along with strength and mobility exercise for lower extremity 3 days week for 45 minutes. Then protocol for task-oriented motor training. So that include flexibility, stepping, simple walking, complicated walking, and treadmill-based walking, sir. Then move on to the protocol for multisensory training that include standing, tandem stance, single leg standing, walking, obstacle training. Both are received 45 minutes equally. Then results, comparison of pre versus post scores of TUC, BBS, NQL in group A. And next one, comparison of pre versus post scores of TUC, BBS, and NQL in group B. And finally, the comparison of post TUC, BBS, NQL in group A and group B. Next, move on to the discussion. Task-oriented motor training increases proprioceptive input, causing better body progression, and sensory burdens on the neuromuscular system will generate loads on the feet. The destruction of proprioception that makes susceptible to the falling. Then, firstly, in neuropathic gait, strength of ankle plantar flexor will reduce and body adopt hip muscle for walking. And in this study, stepping part of training was made a high level of activation of dorsiflexus as well as other different group of muscles. Secondly, accuracy, that made patient pay special attention to decrease the base of support and exert better controlling their balance. Then thirdly, specificity or goal-directed task will improve similar task and conditions. The multisensory group control postural movement, use mechanical constraints of task and availability of sensory information. Then in this study, focus unstable visual vestibular inputs found that peripheral sensory information will trigger automatic postural reactions and generation of anticipatory postural responses, and reduce strength proprioception in the lower extremity that reduce mobility, and mobility reduction association with the depression and isolation, and reduce independence of ADL and social roles. Finally, it will cause direct impact on quality of life. So move on to the conclusion. Statistical significant that in group A, 10.8 as 15.2 and BBS 51.3 as 37.5 and NQOL 37 point as 90.8, and in group B 12.5 as 14.7 and BBS 46.7 as 38.8 and NQOL 59.7 as 97.3 in group B. And so it shows slight improvement were found in multisensory training group compared with the task-oriented motor training. So further study that recommend should be performed use of this technique to measure fall risk among large population to identify its impact on diabetic neuropathy. Okay, thank you, sir.
Moving on to the judge panel.
Yeah, it was very good study.
Thank you, sir.
Ma'am, I have a question. You have included treadmill training, ma'am, in your protocol.
Yes, sir. Yes, sir.
Can you tell about what intensity have you used in the treadmill training for this patient?
Sir, 50 to 60%, sir.
And okay, 50 to 60%. So
yes.
You have used Carvenant's formula and have used it.
Yes, sir.
And any other thing, ma'am, apart from that, what precautions have you taken while doing for this treadmill training?
No other precautions, sir. Actually, the patient is fulfilled the inclusion criteria. Tug is less than 16 seconds as well as 60 meter unsupported walking. So no other specific criteria.
Okay, thank you.
Okay, sir.
Good afternoon, ma'am.
Okay, sir.
Nice presentation.
Thank you,
question
sir.
I had is, why did you keep the criteria that the person should have diabetes mellitus for 25 years?
Is actually, sir, that my previous study that doesn't show about the that means duration of diabetes and all, but I choose the 25 years because even the 25 years with controlled diabetes, they show the specific changes in proprioception and limited strength as well as mobility. So I choose that 20 that means diabetic episodes with 25 years, sir.
No, do you presume that diabetes neuropathy occurs after 25 years of diabetes?
Yes, sir. Yes, sir. Actually, one study that based on Basit et al. In 2004, they concluded that the peripheral neuropathy, especially that peripheral neuropathy that occurs after 24 years of that means post diabetes. Only peripheral neuropathy, sir.
Fine. Thank you.
Okay, sir. Okay, sir.
Yeah, just want to ask you only one thing.
Okay, sir.
What about their diabetic status after giving all this training? Whether there was any changes in the blood sugar level? Did you check that?
No, sir. After that, I didn't check that blood sugar level because I choose that patient with the score is less than 6.5. That means the fasting blood sugar is only 126 mg decibel liter, sir. So next level, that blood glucose level examination is not much mandatory.
Okay.
Thank you, jury. Any more questions? Can we move on to the next presenter? So second presenter from the professional category. The title, the register number 2021 00000012. The title of the study is Impact of Group Exercise Program on Fall Risk in Elderly Individuals, a randomized control trial.
Good afternoon, sir.
Presenter is ready. You can start the presentation once you hear a buzzer, okay?
Yes, sir.
Good afternoon, everyone. I am presenting a study entitled Impact of Group Exercise Program on Fall Risk in Elderly Individuals, a randomized controlled trial. Previous researchers have reported 30% prevalence of fall in healthy older adults. The consequences of fall are extending from physical, psychological consequences like sprain, strain, minor injuries to fatal injuries like fractures, head injuries, sometimes even death. And the fall risk factors which are reported, intrinsic and extrinsic factors, among them strength and balance, are considered to be modifiable risk factors for fall among community dwelling elderly. Therapeutic exercises have been proved to be restorative and accommodative in minimizing the loss of stability by improving balance and mobility. Otago exercise program is considered as a specifically designed fall prevention program, but it was home-based exercise program. And community-based group exercise programs have been proved to be accessible and affordable programs. However, there is inadequate evidence to the date to determine whether components of Otago exercise program given in group setting targeted at at-risk individuals will be effective in preventing falls. So the next slide, please. The primary objective of the study was to determine the impact of group exercise program compared to individualized exercise program on fall risk in elderly individual. And secondary objective was to determine the effect on balance, lower limb strength, fear of fall, and quality of life of elderly individuals. In methods, the study setting was Elderly Daycare Center of Greece because I had obtained a scholarship under Erasmus Mundus European Union funded program, in which the Technological Educational Institute of Western Greece allowed me to conduct the study in their setup. I obtained the ethical permission from Institutional Ethical Committee. Administrative permission was obtained from the directors of elderly daycare centers, which were community centers where community dwelling elderly used to gather for their daily rituals. Next, please. The study was a single-blind randomized control trial. Eligibility criteria was community dwelling healthy elderly, which age more than 60 years, gender both males and females, individuals who were having fear of fall as measured by Falls Efficacy Scale International, that should be more than 19, and those who were not involved in regular exercise program who volunteered to participate in the study. Participants excluded were history of traumatic fall in past year, neurological disorder, those with uncontrolled cardiovascular disease, cognitive impairments, physical deterioration due to severity of associated comorbidity, severe depression, those who were under palliative care and who underwent amputation and having prosthetic limb. Next, please. This is consort flow diagram for recruitment of Greek participants. So during enrollment, 218 participants were screened. Among them, 124 were excluded. Out of them, those were not meeting the inclusion criteria, and 45 declined to participate. So 94 participants were randomized to both the groups, experimental and control, by permuted block randomization method, in which 47 were given experimental group and 47 were allocated to control group who received individualized exercise program. The follow-up was taken at 10 weeks immediately post-intervention, and long-term follow-up was assessed at 6 months. So at the end, 41 from experimental group were analyzed, and from control group, 32 were analyzed. Next, please. So outcome measures used for the study were timed up and go test, which was used to assess the fall risk, Falls Efficacy Scale International used to assess fear of fall, Biodex balance system, which is considered as a standardized equipment to assess the balance. The two components of Biodex balance were used, that is modified clinical test of sensory integration of balance, which is used to measure sway index, and limit of stability, that is dynamic control of base of support over the center of gravity. Then 5 times sit to stand test was used to assess lower limb strength, and short form 12 was used to assess the quality of life. Next, please. Next slide, please. The intervention protocol was consisting of warm-up, balance retraining, and lower limb strengthening exercises. The duration of intervention was 2 times in a week for 10 weeks. Initially, the exercises were performed for 30 minutes, then gradually progressing to 60 minutes. In experimental group, 6 participants performed exercises at a time, and the same set of exercises was implemented to control group, 1 participant at a time. Next, please. The warm-up consisted of spot marching and mild stretching of all the major muscle groups. Then lower limb strengthening exercises were derived from Otago exercise program. The intensity of these exercises were determined by rate of perceived exertion, that is 12 to 13 initially, progressing to 16, and first initially we gave 1 set and progressing to 2 sets, 3 sets, and targeted muscle groups were hip flexors extensors, abductors, knee flexors extensor, ankle plantar flexor, and dorsiflexor, which are helping for gait. In balance retraining protocol, exercises obtained from OEP were given, that is sit to stand, knee squats, tandem stance, single limb stance. Initially 10 repetitions with support, progressing to 1 set, 2 sets with support, and then 3 sets without support. Again, tandem walking, walking backward, sideways walking, walking and turning around. These exercises were given initially with support and then without support. At the end of 10th week, post-intervention assessment was done and 6 monthly follow-up was taken as a long-term follow-up. Next, please. So these are some experimental group, individualized control group. Next, please. So in results, the results were analyzed by SPSS 20 software. In this first, there were 3 points of time. For 1 indicates baseline, 2 indicates 10 weeks follow-up, and 3 indicates 6 monthly follow-up. So fear of fall as measured by Falls Efficacy Scale International gave that both the groups improved, reduced the fear of fall and improved the amount of confidence by showing good score on APS. But at the end of 6 months, the effects were not retained in experimental group, whereas the effect was retained in control group. Next, please. When both the groups were compared, experimental versus control, fear of fall showed no significant effect. That is, both the group were equally effective in minimizing the fear of fall and none of them was superior. Next, please. Same effect was shown by timed up and go test, in which both experimental and control group showed that compared to baseline, both the group showed post-intervention improvement in fall risk. Fall risk was significantly reduced in both the groups, showing none of them was superior. Next, please. Next, please. Again, 5 times sit to stand test for assessing lower limb strength showed the significant effect. Within group analysis of experimental and control, both were effective in increasing the strength. And between group analysis of experimental and control, all the 3 points of time showed no significant effect, showing that both of them were superior. Next, please. Balance was determined by MCT SIB. Again, same result was shown. Experimental and control both showed statistically significant improvement. Next, when compared to experimental and control group at 3 points of time, none of them was superior. Both were equally efficient in improving balance. Next, limit of stability. Both the groups were equally efficient in improving the limit of stability. Next, experimental and control, both the groups were equally efficient. None of them were superior. Next, please. As quality of life was measured by PCS, experimental group showed that at all the 3 points of time compared to baseline 10 weeks and 6 months, experimental group showed highly statistical improvement, whereas control group, it showed significant improvement, but the effect was not sustained in control group for physical component summary of quality of life. And both the groups, when they were compared, both groups showed significant improvement and none of them were superior. Next, please. When mental component summary of quality of life was compared, experimental group showed highly statistical improvement in all the 3 points of time, whereas control group showed that the effect was not sustained in control group at 6 monthly follow-up. Next, then repeated measure ANOVA for mental component summary showed statistically significant improvement between experimental and control group 10 weeks post-intervention. But again, this effect was not continued at the 6 monthly follow-up. So the result of the present study was supported by previous researches, which stated that strength and balance improvement reduces fear of fall and improves functional status, preventing deconditioning and further reducing the fall risk. The sway reduction, which was obtained in MCT SIB, was attributed to improved strength of ankle dorsiflexus, which plays primary role in static postural control and reducing postural sway in elderly. An increase in limit of stability, which was the dynamic control of balance, was improved due to neuromuscular control during standing, and balance retraining exercises challenge the contribution of somatosensory system to balance, and the input of cutaneous receptors increases reliance on the proprioceptor. And the result of lower limb extremity strength improvement was adopted due to resistance training with increased motor activation and myofiber hypertrophy, which increases the muscle mass, strength, power, reduces the difficulty of daily tasks, and enhances energy expenditure of the body, and promote participation in spontaneous physical activity. Resistance and balance training both improve the leg muscle strength and proprioception of neuromuscular system through muscle contraction and stimulation of proprioceptive sense, which further improved the balance. Experimental group showed more significant improvement in mental component summary of quality of life. The possible explanation for which was the improvement was attributed to the interaction, social interaction and participants were working towards the common goal, and that social interaction gained confidence to hold their own responsibility to perform exercises in union. Whereas individualized exercises late, even if they were showing effect, there was boredom and the adherence was lesser in individualized exercise program, and there was no motivation. So the conclusion of the study stated that group exercise program had positive impact on reducing the fall risk, fear of fall, and improving the balance and lower extremity strength and quality of life after 10 weeks of intervention. These are some references. Thank you.
Moving on to the juries for question and answer.
It was a very good study.
Thank you, sir.
I just want to
Thank you
ask
so much.
the registration number is 215 and for the paper the number is different, right?
Yes, sir. Yes, sir. That is 12.
That is
This
12,
is for
right?
yes, sir.
This is
Yes,
for
sir.
the
This is for Jerry. Yes, sir.
So how many sittings you have given for the group program?
Sorry, sir.
How many
Session.
sittings patients for the
Sir,
patients?
sir, 2 times a week for 10 weeks. So total 20 sessions were given, sir. Initially for 30
Are
minutes.
they allowed to do the exercises after without supervision in the house or in the centers?
Sir, after yes, sir. After 10 weeks, they were given exercise
No,
handouts.
not after 2 weeks.
The
You are giving only 2 weeks, 2 days,
No.
right, in a week.
Yes, sir. No, sir. After that, they
4
were
weeks,
not.
4 days,
No,
are they
sir.
allowed to do the exercises?
No, sir. No, sir. Those who were not involved in regular exercise program, only they were included. So they were not allowed to do
Whether
other than this program.
they can do what exercise you have taught to them, they are eligible to do that exercises?
No, sir. No, sir.
How you are monitoring whether they did or not?
Sir, they were told not to perform the exercises other than these two. And sir, that availability of the participants was based on their routine only, sir. Other days, as this study was conducted in Greece, other days they were having some religious activities as well as some music classes, and they were involved in some social activities also.
Okay, very good study, ma'am. Congratulations.
Thank you so much, sir. Thank you, sir.
Madam, good afternoon. It was a good
Hello,
study
sir.
and a good presentation.
Thank you, sir.
Ma'am, did you use any minimization program? Because randomization, it leads to variability at the baseline. How did you manage to have an even baseline?
Yes, sir. Sir, actually, we made sure that participants whose age, those who were community dwelling elderly, whose fear of international, and we use IPAC. Previously, they were not doing any exercises other than this intervention. So only they were included, sir.
Okay, fine. Which year you conducted this one, the study?
Sir, it was conducted from 2015 till 2017.
Okay.
Yes,
fine,
sir.
madam. Thank you.
Thank you, sir. Thank you, sir.
Good afternoon, ma'am. It was an excellent study, ma'am. What were the challenges you faced because you did this study in abroad? What were the challenges you faced
Yes.
while doing this study, ma'am?
Sir, challenges we faced, sir, first challenge was since it was done in community center. So that study, we wanted to make it double blind, but practically it was highly impossible to blind the participants, because when we informed them through the informative lecture about our study, so people understood that there is individualized exercise program as well as group exercise program. So it was difficult to blind them, but we informed them that based on permitted block randomization, you will be allocated to both the groups. So those who, some of them, they were unhappy, those who wanted to get participated in the group. So they directly declined to participate.
Okay. And did you have a separate guide, ma'am? You had a separate guide over there?
Yes, sir. Yes, sir. Dr.
Okay.
Chepis was my guide in Greece.
Okay.
So, yes, sir.
That's good, ma'am. Great. Thank you, ma'am.
Sir. Thank you so much, sir.
Any more questions from the jury?
Shall we move to next?
No, sir, we can take the next candidate.
Okay, sir. Okay.
Thank you, everyone. Thank you, organizers and juries.
Sir, with this, we are finishing the presentation, paper presentation. one of the candidates.
One more missing is no right PG category. One student was not taking.
We tried to contact her and she's not picking up the call as well as not responding to the messages. So we have no other options, sir. Okay, sir. Thank you, jury. Thank you so much for your patient cooperation.
Thank you, Arun sir. Thank you, Vishnuvardhan sir. Thank you, Dharmang sir. Thank you, Srihari sir. We request you to send a score as soon as possible so that we can announce.
We will send it to Duna madam.
Yes, please,
sir. Sure, sir.
Yes.
Please.
Yeah.
I will
Thank you
send
so
by
much,
mail, ma'am.
Chandramohan sir. Thank you, ExRx India and the GERICON conference for inviting us as a jury member. Thank you, Duna ma'am and the team for organizing such a wonderful conference, ma'am. It's really great to always work with ExRx India because they come up with so much of new techniques and advancement in physiotherapy to create awareness among physiotherapists and around the globe. This is really appreciable, sir. And it's a great honor for us to be in the team of ExRx as a jury member or as an a resource person or wherever you invite us. Thank you so much, sir. Thank you so much, ma'am.
You all are included with us, sir.
Thank you, sir. Thank you, Chandramohan sir. Thank you, Duna ma'am.
Thank you, Vishnu sir. Thank you.
Thank you, sir. No, this is,
Thank you, Srihari sir. Kindly send the score sheet to me. I will forward it to Duna. Otherwise, Duna madam's number I will share with you.
Sure, sir. No problem. Thank you.
Yeah. Over to Jasil sir. Kindly
unmute, sir.
With this, we are winding up our presentation session, sir. Thank you.
And thanks to Jasil sir too for handling this e-paper presentation session very well. While actually I was absent in this presentation session for a while, was taking a little break. Thank you, sir, and thank you everyone. Thank you, Chandramohan sir too for handling.
Jasil sir, we will handle. I think there are a lot of disturbance from your side. So, madam,
No, it's from a participant, sir.
I think
it's okay. We will be winding up this session and we will be starting our post-lunch session at 4 p.m. And I will be inviting everyone in behalf of our GERICON team to join the post-lunch session. And thank you all. Bye-bye.
Thank you, ma'am. We will send the score sheet as soon as possible, ma'am. Thank you.
Yes, thank you, sir. Thank you so much.
Thank you, Jasil sir.
Thank you, sir.